had with us. And I think Dr. Alison referred to that when she said that, we didn't have to recreate the learning. We took what is best within us and we were able to leverage it. During this process, in an endeavor led by Dr. Sai Harinath and Dr. Ravi Mahajan, during the COVID crisis, we trained 130,000 medical practitioners in the use of ventilator. And I think, the importance of ICU can never be underestimated. If we look at our country today, we have 94,000 ICU beds, and out of which 59,000 are in the private sector. But beyond that, as we look into the future, we recognize that more and more people will come into the hospital system, especially for ICU care, which is why it is extremely important that we think beyond just the Apollo patient, that this is Apollo's way of reaching out to society, reaching out to patients wherever they are, to make sure that they come through this critical episode in a very successful way. And I believe we've done that. We've done that through our research. We've done that through the publication of our Red Book. And to all of those who are part of this, my gratitude, because you have really helped save lives. And I think going forward, if you look at what Yale University has done, which is really a very established telemedicine network, and this of course has saved many lives. If you look at what happened during COVID, where there was intense pressure on intensive care, we've now found a solution to look after patients beyond just those in our beds. And I think for this solution, I thank the entire team, because without your effort, without your commitment, we would not have been able to put this together. As I look forward, I refer to the study that was made by the Indian Journal of Critical Care. And I think in that it showed that the combined usage of technology, of trained doctors and nurses, and the knowledge, which is a critical part of it, really improved mortality rates. And what more can we ask for? What more can we ask for but a healthy patient who survives the worst of times and comes out with a smile. So my deepest gratitude for all of you who have been part of that process. And as Apollo, we've gone beyond thinking of only our one hospital in Uni's Road. And let me be very selfish here. When I heard Dr. Mahajan had joined the team and Dr. Sai Harinath, I said, I really want them here. I want them to be in the Apollo system first, and then we can share it with the rest of the community. But I think Chairman and Preetha were very firm. They said, no, we need to share our intellectual resources, we need to share our doctors, and we need to provide the best clinical outcomes, not just for the Apollo patients, but patients beyond our system. Finally, I look at the name, ACEC. So ACE for us is all about Apollo Clinical Excellence. And Apollo Clinical Excellence getting magnified with Apollo, with critical care, I think is something that will change the lives of many. So I wish you all the very best. I know that you have a great opportunity in front of you. And, like Winston Churchill said, never let a crisis go to waste. I think we really converted that crisis into a wonderful opportunity to save lives. And my deepest gratitude to all of you who have done so. May God bless you to continue your wonderful work with the day. Thank you.
Thank you, Ms. Sunita, for such kind words and thinking of going forward. You're absolutely right. So thank you indeed for that direction. And that, ladies and gentlemen, brings us to another phase of our program, and I will invite Sam to take us through that phase. Sam, please.
Thank you, Professor Martin. I believe most of the questions have been addressed on the chat, but we want to leave some room for any fresh questions from our media folks who have joined today. I'll probably speak on their behalf on 2 or 3 questions which has been posted on the chat. Quickly, I think there are 4 or 5, I'll club it. One is, where will these e-ICUs be available in remote locations? And the cost to patient of e-ICUs against regular e-ICUs. So what will be the cost difference? And I think there is another question around the staff on ground selection process.
I think it's been answered on the chat, but I'll repeat that for you. There is no restriction in terms of a location because of the technology. We can have an EICU in any location. As Chairman said, they have it up in the Himalayas where it is difficult to actually reach the place. So when we could have it there, we could have it at any place. But the focus is really on places where critical care as an entity is non-existent, but much required by that local population. So that's going to be there's no restriction in going to any place in the country for this program. In regards to the cost, it's already on the chat. The cost is going to be much lower because the patient is remaining in the hospital at the periphery. The medical cost will be much lower. And second thing would be, as I said when he was speaking, the cost of traveling and relocating to another city and also losing their daily earning because they happen to be away from their home will also be saved. So overall put together, the cost of managing a patient on the EIC in a remote location would be significantly lower than actually a patient traveling to a large hospital to get trained. And the third part of it was in regards to the training of the staff. As you already heard, more than 150,000 staff were actually trained on the use of ventilators even as the pandemic was on. Now, as a part of this program, first thing that would be done is all the hospitals that enroll or all the facilities that enroll for this program, they would be first trained on how to use this platform for the benefit of their patients. That would be the first step of the training for the local staff. Then the next step would be to upskill their capabilities, their expertise, their skill sets, so that they can start gradually doing more and more for the patient at the same remote location, to an extent where someday they will become self-sufficient. So that's about the training part of it. Dr. Ravi and Sai, you want to add, please add on.
I think, Dr. Prasad, you've covered everything. I think the one thing to say is that what is really important at remote location is for people to recognize the sick early so that they can get in touch with the hub unit early on, because quicker you recognize illness and illness becoming critical, quicker you get the advice, better it is for the patient, and patient is more likely to remain on your location. So one of our training objectives will be, as Dr. Haripsa said, to upskill people to recognize when the illness is becoming critical illness, so that they can refer their patient or get access to us fairly quickly and get the right advice so that patient is stopped from becoming so critical that they have to be transferred. So it's the skill set right from the training to the ventilators to recognize the critically ill, but also managing some basic skills if patient is at that level of sickness. So those are the components that we put together as part of our multidisciplinary program. It's not only directed at doctors, but also at nurses, but other medical healthcare workers who would be the part of the intensive care unit. Sai, I'm sure if you want to add anything to that.
Sure, thank you, Dr. Mahajan and Reddy Prasad. I think honestly, good critical care is not expensive. It actually involves looking at the patient all the time continuously. And having a remote command center allows you to make sure that things which work, we know very well that there are some things which work for patients. For example, keeping the head of the bed elevated prevents pneumonia. On a ventilator, you need to have very particular settings in COVID ARDS, for example. Also watching the glucose, preventing blood clots. All of these things don't cost anything, but you need to do it all the time. The analogy often given is that of aviation. When you're flying a plane, you have to check 1,000 parameters all the time to do it safely. So when you're flying a plane now, you don't know who the pilot is, you don't know who loaded your luggage, you're not even sure who the air traffic controller is, but almost always we take off and land safely. Healthcare and critical care is like that. And this can be done with the use of a remote command center. And doesn't matter where the patient is, you can actually monitor them all the time. When you're at the bedside, you're often distracted by many other things going on. Because we're in a command center right now, we're able to very systematically look at every patient, look at all their parameters, and give advice to the remote team. And that, I think, is the power of technology along with the ability to actually do things in a systematic way. But this would not happen without support of a big team. Nurses form a critical part of this, and our mission is to continue to educate and upskill our nurses. In addition, we need managers, like Pankaj here, for example, who's been helping us for several years now in making this run. In addition, we need technologists who can help us keep the systems going. And all of this, of course, is electricity. So these are all the different components which are involved. But ultimately, it's about the desire to help the person on the remote side that really costs nothing. And the ability to connect with them is what Apollo does really well.
I just want to add on here both the Ravi, Sai, and the huge army of intensives across the Apollo system. What they've done is tremendous. As Dr. Ravi said, it's more important to identify a patient who is going to become ill before he becomes really ill. So they have actually analyzed the entire data, put it into machine learning, and created an artificial intelligence tool which actually predicts a possibility of a patient turning bad or becoming critical. Using this tool, I think a lot of patients will benefit from treatment before they become ill, and thereby, apart from saving lives, it also saves them a lot of financial burden that they would have incurred if they had become ill.
Thank you, Professor, Dr. Sai, Dr. Mahajan. And I think one last question, because most of them have been answered already. What are the plans for the Apollo Center of Excellence in Critical Care 1 year from now, both in terms of patients covered and in terms of new skills added?
Again, I think I answered this on the chat. So right now we have one hub in Hyderabad which has been operational, which is the pilot hub, which is about 500 beds. And then the end of the next week, Dr. Ravi is operationalizing 2 more hubs, one in Chennai and one in Madurai, with another 500 beds will come in 15, so it will become 1,000 beds. And then there are now plans to expand it into Delhi, Bombay, Ahmedabad, and other locations, Bangalore. And the aim is to have 10,000 beds on the system on the ICU platform within a year's time.
Thank you, Doctor. I think that will be all from our media folks. And any last words from any one of you before we close the session?
All yours, Dr. Reddy.
First of all, thank you all, and thank you, your Chairman, thank you, Ms. Sunita, Ms. Preetha, and Ms. Sangeeta in her absence. Dr. Hari Prasad, for being such a support, and thank you, the team, for putting it all together. Dr. Nandini Ali's team, Saurabh, Mayank, I can't even name, so many people have been involved in all this mega. People have been working till the last minute, last night. The website has been launched, and so you're more than welcome to go on the website and see all the things, all the questions that you have would be answered there. But if there are further questions, please get in touch. The launch doesn't mean that we begin and finish here. There is this is just the beginning of the journey, and we're all in it together. So media, the government officials, us, the international collaborators, everybody is in it, so let's all work together towards that. I will invite Chairman, since Chairman you're here, for the final word, and then we can close the session. Thank you very much.
I'm very pleased today. As I said, this is an important day. COVID has taught us the need for expertise in the clinical area and what significant impact it can have on people. And very nicely, I has shown what they are not doing outside of us. So I think what we need is, as I mentioned, the most critical part of healthcare is the emergency care. So here we need to see how we can coordinate, how we can digitize, how we can bring the artificial intelligence, give the expertise to the patient who first will get the expanded access to people. That is our first aim, to give access to a number of other people. 10,000 now, 100,000 later, but it's unlimited access. The need is so much there. So I think our aim is to start it now. We want to give expertise at remote areas. This is where I think satisfaction will come from in healthcare. We all need to go to the goal of sharing our expertise and giving our very best to that person who needs it. I thank all of you and appreciate the efforts put by Dr. Mahajan and the whole team. But Hari was very positive of what was done and what God bless all.